This is Mon Health Talk, a weekly program focusing on the dedicated physicians, nurses, and staff at Mon Health, the region's premier community hospital system. People with skillful hands and bright minds using state-of-the-art technology. We don't just practice medicine, we care for people like family. That's why at Mon Health you can feel the difference. Once again, welcome to this edition of Mon Health Talk.
Good morning. Welcome into Mon Health Talk. I'm Dave Wilson. Our guest this morning is Dr. James Holehouse, gynecologist at Mon Health Preston Memorial Hospital. Good morning, Dr. Holehouse.
Good morning.
Hey, thanks for taking a few minutes with us. We'll jump into the subject at hand in just a moment, but let's talk about you. To get started, first of all, tell us a little bit about yourself and your education and background.
Well, I've been a physician in the Mon system over the past 30 years. I was at Mon General for 23 years, and I've been up here in Preston for the past, I did them concomitantly, but for the past 16 years. So I worked at both places during that time. I did my residency at the University of South Florida in Tampa, which is where I lived for 18 years. And I moved up to West Virginia in 1987. Practiced first in Buchanan for a couple of years and then came to Mon General from 89 until now.
I got to ask, Dr. Holehouse, with it being, 40 degrees and we're talking about snowing tonight, what drew you from sunny South Florida up to West Virginia all those years ago?
Hey, don't underestimate. West Virginia, particularly Morgantown, is an absolutely gorgeous place to live. I wouldn't trade it. Now, I wouldn't mind spending a little time in Florida in the wintertime, but actually I enjoy winter sports as well. I wouldn't trade it. I wouldn't trade it at all. I love it up here.
We like to complain about the weather, but most of us wouldn't trade it either, to be honest about it. We just like to gripe every once in a while.
I would never. I hated Florida for 6 months. It's so hot. And then I have to admit, when I lost the hair on the top of my head and got sunburned, that was the that was it for me. I wasn't adapted to the sun, so I like it up in the morning. I'm actually from New York originally, so this is kind of halfway in between.
Why did you choose gynecology as a specialty?
Well, I started out in family practice at the University of South Florida, and then I thought that I really enjoyed doing surgery. I delivered babies, enjoyed that, and I thought that I wanted to get into a little bit more of a surgical subspecialty, and actually I enjoyed taking care of women as well.
So we're talking to Dr. James Holehouse this morning, gynecologist, Mon Health Preston Memorial Hospital, and we'll focus in generally on gynecology today. Let's just start, I guess, would be the beginning point. At what age should doctors or should girls start seeing a gynecologist?
I'm assuming they're healthy and without any problems. But if they're healthy otherwise, usually you don't need to get exam or pap smears and stuff until you've been sexually active for at least 3 years, or it's generally thought that age 21.
And how often do you once you start seeing patients, how often do you see them on a regular basis?
Well, again, for healthy patients with no complaints, the recommendation is pap smears every 3 to 5 years. So for a healthy female, they really don't need to be seen other than once every 3 years.
And I would imagine you'll be seeing them more often, especially if there is a bun in the oven, bundle of joy on the way. You'll be seeing them a little bit more often than that.
Of course, yeah, and after that you establish a good relationship, and then you, in OB/GYN, a lot of times you do a fair amount of primary care for women, those that are not having any significant problems. I will say one thing that I know the time is fairly limited, and they asked me what we wanted to talk about this today, and I have been doing over the past almost 20 years doing bioidentical hormone replacement therapy for women. And one of the areas that is completely ignored in most areas, both in internal medicine and family practice, and unfortunately oftentimes in OB/GYN, is evaluating women for testosterone deficiency syndrome. It's a very serious problem, and it's oftentimes ignored, both in the perimenopausal years as well as in the menopausal years. So I wanted to make sure we we hit on that before we lost, because I know the time goes fast on the radio.
You are exactly right, and that sets up our next segment perfectly, so we will jump into that. So let's go ahead and take the break so we have plenty of time to discuss that. We will do so when we return. Talk to Dr. James Holehouse, gynecologist, Mon Health Preston Memorial Hospital, and we will return to Mon Health Talk right after this on WAJR.
Now back to Mon Health Talk, a discussion of the issues, people, and procedures in healthcare today. If you have a question for one of our healthcare guests, call now at 304-296-0041.
Our guest today is Dr. James Holehouse, gynecologist, Mon Health Preston Memorial Hospital. And before the break, Dr. Holehouse, you were talking or had brought up the subject at hand, the focus, talking about testosterone deficiency. Can you explain a little bit deeper what you were talking about?
Yeah, I'll just use an example. I had a patient that I shared with a prominent radiation oncologist in town. She had breast cancer, and I called him about the possibility of using some testosterone because she was highly symptomatic from her treatment. And he said, "I have no idea why you would be treating a woman with male hormone." And that's kind of the mentality out there. But if you look, you will see that if you draw the blood of a woman, they definitely have testosterone in their blood, and it's the most active sexual hormone in the body as compared to even estrogen and progesterone. It's far more prevalent. In fact, when you measure estrogen, it's done in picograms. When you measure testosterone, it's in nanograms. A picogram is 10 times greater than a nanogram. So it's just significantly, it's a very significant hormone that is highly ignored, and that's why I wanted to bring attention to it. The symptoms that are associated with it, probably the things that bring patients in the office could be in the area of loss of sexual drive or libido, but far more than that, there's tremendous number of postmenopausal women who have bone density loss, loss of muscle mass, and of course loss of sexual drive. So to ignore that and not to give the patient an option to at least, that's true for hormone replacement in general, but specifically and even more so with testosterone. The reason I'm fairly passionate about it is that the risk-benefit ratio is so great. The risk of using testosterone therapy in a female is so low. The low doses that we use, the risks are close to zero. Now if it's abused, if it's not followed, if it's not used properly, of course there's problems. But for the average patient who has, we check their levels, and if they're low and they're symptomatic, there's no reason in the world why you would not encourage them to go ahead and get started on some low-dose testosterone. So it's an area that's ignored, just basically ignored, just even with a very prominent, intelligent provider such as that is saying, why in the world would you give a female a male hormone? It's just misguided. And I hate to see that patients, especially patients who are struggling so much with loss of estrogen and progesterone and on chemotherapy and all that, not to be given some options with testosterone. And I would encourage the listener to go to a website. It's called hormonebalance.org. And in that, you'll see a lot of very good publications and articles about the use of testosterone, the myths and misconceptions of testosterone, the use of testosterone in the face of breast cancer and all. If a patient came to me, I'll give you what the general protocol is. For patients who are going through in the throes of menopause, most patients agree that they do better being on some hormone replacement if they're not at high risk. And we generally continue that for about 5 years. After 5 years, we try to get them off the estrogen and progesterone and testosterone and get them on testosterone only, and they do very well. For some patients that may be at a little bit of risk, we know that testosterone will produce a little bit of estrogen. So if they have a history of breast cancer, we may give them a little Arimidex or Aromacin to block that estrogen. But the benefits are enormous as far as bone density, muscle strength, depression, decreased risk of blood sugar and diabetes, and sexual drive and all. So I think it's an ignored area, and I just wanted to make sure we emphasize that women were aware of this, and if they have any if they want to look up that information I've given them, and if they want to give us a call to maybe look at their individual circumstances and see if they would be a good candidate, I think it would be worthwhile.
So how do you apply the treatment? Is it through the form of a medication you take? Is it a treatment you have to come into the office to receive? How does it work in practicality, I guess?
Good question. You cannot take it orally. It's not. It's just contraindicated oral. However, using a cream or a gel or an injection or an implant. So there's multiple ways that you can use it. And according to the androgel, which has been used for years and years for men, has gone generic. So it's really inexpensive now. So we tend to use the androgel. We use bioidenticals through, we use Women's International. It's a cream form. Some patients who are younger will go with an injectable form. Some people just don't absorb it. There's also a patch as well. Some just don't absorb it that well, so they'll do the injections. But otherwise, most patients will go either with a pellet or a cream.
So what is some of the feedback you have heard from patients who have benefited from this treatment?
Well, there's been multiple studies, and if you go to that article, there's a menopausal symptom review on that, and it's overwhelming. It's highly beneficial. I don't know. Now, patients who maybe are ethnic or Mediterranean stuff have a tendency to have potential side effects with testosterone. We will use spironolactone, which is a diuretic to block that, the conversion of testosterone to DHT, which can cause some of those side effects. But by and large, there's very few. If you're using it properly, you're keeping it within normal ranges, there's essentially no side effects to it. If you're overdoing it, then there's always going to be side effects. So taken responsibly and under medical direction, it's as far as benefit versus risk, the ratio is phenomenal. As compared to maybe estrogen and progesterone, things like weight gain and bloatedness and risk for breast cancer and heart disease and clot. At the doses that we're using in women, those things are essentially non-existent. So getting the most benefit for what you're doing, the lowest risk, hormone replacement therapy, I think testosterone should be your first approach, other than if they're highly symptomatic and they need some estrogen and progesterone early on.
Talking to Dr. James Holehouse, gynecologist, Mon Health Preston Memorial Hospital this morning. Who would benefit the most from this? You've mentioned a bevy of different patients this morning in the show, but again, we're speaking generally. Obviously, every case has its own nuances, but who benefits the most from this hormone therapy?
Well, I think the easiest thing to do is just check lab levels and see. I mean, if they're deficient, now there's normal ranges, which goes from 0, which I kind of think is a joke, to 4.2. That's a normal range. So if a patient is in the lower, less than the 10th percentile, most people go, okay, you're normal, we'll send you out the door. Well, they're less than the 10th percentile and they're symptomatic. There's no reason not to treat it. I think the reason most people don't get treated is because most practitioners are not real familiar with the treatment. It's just a little fairly novel to them, but it should not be. Interesting, even in the elderly patient who has failure to thrive, is not doing well, is not eating well. I've had a number of patients who do extremely well with taking just a 0.1 cc every 2 weeks of little depot testosterone or some cream. They do extremely well, which is a whole other area as far as postmenopausal and treating the elderly. Again, the risks are so low that there's no reason not to do that when they're struggling in such a way. But again, oftentimes it's just not an option for them. And that's the main point of this whole conversation, is not that I'm promoting that everybody get on it and everybody should be using it. If you don't use it, you're wrong. But I do think you're wrong if you don't look into it and at least offer it as an option, because it does cover a lot of problems. And in my practice, it's been very rewarding to see how well patients do on testosterone replacement therapy.
Dr. James Holehouse is our guest this morning, Mon Health Preston Memorial Hospital. We'll take our final break. We'll be back to wrap it up in a moment. You're listening to Mon Health Talk on WAJR.
This is Mon Health Talk, providing a window into the Mon Health system and the dedicated healthcare providers who work there. If you'd like to comment or ask a question, please call 304-296-0041.
Got just a couple of minutes left with Dr. James Holehouse, gynecologist, Mon Health Preston Memorial Hospital this morning. And Dr. Holehouse, where can folks find more information or reach out to you if they think that hormone therapy, or they just need to make an appointment with a gynecologist? Where can they find more information, and how can they reach out?
Sure. I'm up here at Preston Memorial. Our number is 304-329-4701 or 329-1400 is the main operator, but 4701 will get you into the physician office practice. And I'm glad to see anybody. You know, if you're comfortable with your own OBGYN that you're seeing and you just want another opinion or can work with them, or however if they're not comfortable with that and you want to at least explore that a little bit on your own, I'd be glad to set up an appointment and discuss it with you.
And you've mentioned it a couple of times, and we have about a minute here. What is the main point you want folks to take away from our conversation this morning? That
testosterone is the most powerful hormone, sex hormone in the female, and that it should not be ignored. And that just like any other deficiency, if we're checking thyroid, if we're checking insulin deficiency, we treat them, I think, equally so with testosterone, since it's so powerful and so strong and so effective that we should be checking those levels with any patient with complaints. And it should be a part of your armamentarium with treating postmenopausal women.
Dr. James Holehouse, gynecologist, Mon Health Preston Memorial Hospital. Thank you so much for the time this morning, Doctor, and I'm sure we'll talk again soon.
Yeah, excellent questions. Thank you.
Anytime. Dr. James Holehouse, gynecologist, Mon Health Preston Memorial Hospital. And you can always find out more information. Go to monhealth.com/OBGYN.